the clicker. Maybe the hardest part of the day. Okay, so here we go. I'm going to go faster because this is round 2. If I can get this to move. So, if we back up for a minute, I want you to remember this is a progression, right? When I work on CDI and someone came in for open heart surgery, the history was almost identical on every patient. What is the history? Hypertension. So normally, and if you think about the progression, right, it starts with CAD, right? Because you've got the arteriosclerosis, the atherosclerosis, you've got the cheeseburgers lining the walls, and the walls are hardened, right? So that leads to hypertension. What else is there when you figure is the commonality of in their history? If you have years of chronic hypertension, what does that usually lead to? So remember that it's like a fire hose on your tiny little vessels. So hypertension, why they call it the silent boom, is because it usually wrecks out your kidneys. Sometimes your eyeballs, that's why they have the visual changes. But for us, they usually have some renal involvement. So we always have CD, hypertension, renal, and one more. What else happens to you if you eat cheeseburgers all the time and don't actually? Now, in the land of cardiac, here we go using analogies. Does anybody know why diabetes is so hard on your heart? The sludgy is part of it. And the same little vessels that are in your kidneys are in your arteries. Okay? So the combination of sludging, where you've got very thick blood moving through these vessels, that doesn't go well. The flow of the blood decreases perfusion. So yeah, usually that was the 4 trifecta. You had CAD, hypertension, the renal insufficiency, involvement, whatever, and then you're diabetic. The other thing that would happen with diabetes is when we talk about then going to foreign cabbage, where they're taking out the greater saphenous vein, usually sometimes they'll leave left artery, but they're splicing sections of your vein and they're sewing it around the blockage. If you have diabetes, what does that do for your tissue? It just turns into slush. So they had a hard time sewing because the tissue just dissolves. So it's what I want you to appreciate is it's all interrelated. Okay, you don't just have heart disease, you don't just have diabetes. When you go in for the surgery, it's all that impact the rest of it. Does that make sense? If you think about what do we do if someone has an MRI? Ideally, we take them for a cardiac cath, right? What do we do in a cardiac cath? How's that going to affect your kidneys? We shoot that. So someone who already has renal insufficiency is going to now have, we're going to probably have renal more than insufficiency. So a lot of times the treatment for one disorder is going to have a negative impact on the other. That makes sense? And they're just going to go with a greater good. So when it says, what are the interrelated concepts? If you have a perfusion problem, what other problems do you have? Oxygenation. Okay, number 1, and what's number 2? By definition, if you have a perfusion problem and an oxygenation problem, what's your third and probably biggest problem that's going to kill you? So if you, not usually impossible, but unless you start printed on your death certificate as, myocardial infarction caused the death. But what really happened was, you got so acidotic you died. That's just true. People who are critically ill, particularly like, if they went, say you collapsed at the Walmart and they resuscitated you and that sort of thing, you can, and usually are, post-arrest, those guys have both metabolic and respiratory acidosis because you lost them on both parts. So, how will the nurse assess perfusion? This is always fun. So, how do we assess perfusion? There's one. What's the first thing you're going to do? What's the first thing you notice? Yeah. I can, working in ICU where everybody's in a glass house. Yeah, I can tell walking by what the night's going to be like before I don't have to lay hands on you yet. The other thing, weirdly, before your vital signs, it's a bad word been on the hospital, but in the ICU we still have Foley's. I can tell by looking at that Foley bag, because before your vitals change, your urine output's going to change. And so if it's very concentrated or to live again, a lot of times when people are having an MI, blood flow is just here. So if they survive an MI, a lot of times afterwards you'll see your creatinine rise, your liver enzymes rise, whatever. A lot of people that survive the initial event and then die a few days later die from multiple organ syndrome failure. But what that means is your kidneys took a hit during the MI, or your liver, or whatever. And yes, we took you to cardiac cath lab. Yes, we opened the coronary artery. The damage that was done was done. So, okay, so color, we know vitals. What else? And this is where, the nerd in me is going to come out. I told you before, and I think probably gave you a hard time. So when you put your stethoscope on someone's chest, what are you? I mean, you guys are going to please don't take. You tell me, what are you listening for? Just to see that they have one?
It wasn't for the cells, but now the heart valves are open.
Okay, so you're listening for that love done. And you hear that. You're like, okay. This makes sense. If you're not listening for other things, you won't hear them. So, yes, I should be listening to love done. When we talk about an S series, remember what I said? So S1 and S2 is that love done. But what is the S series? Just love that ding. So, indicating there's another instrument in the band. I don't know, sounds weird. But that ding is from the fluid. That usually means heart failure. A S4 technical term is non-compliant ventricle. It's the blood hitting a very stiff wall. Just more of a lower pitch kind of thud, blood does go through. Murmurs, what are murmurs? Why, when would you hear a murmur? There's a lot of time. You hear
Squishy sound.
So they will say, systolic, diastolic, but clinically listening is usually kind of in between. You hear blood, it's in the middle. Well, what does whoosh sound mean?
It's okay. Friday is through.
Because we haven't got the valve lecture yet, somehow murmurs relate to the valves. And a valve that doesn't close properly gives you that whooshy sound. So murmurs, a lot of times kids will have murmurs, and they are not significant because kids just had a really good heart. It's so strong. It's just the force of it's making a whoosh. But you get to adulthood or later in life, that whoosh means that the blood's coming back the end of the day, what does that mean for your heart? Say, for example, if you've got, say, the mitral valve between, say we're talking about the mitral valve, and this is the left side of the heart. Here's a really nice heart. And we got a valve here. If this, instead of looking, well, let's do it like this. If this one looks like this, and this guy looks like that, then every time this should be pumping out to, now you know why it's called signal. I can't draw. Every time it's pumping out to the body, some of it goes here, some of it goes here. Makes sense? Because this is not closing the door. What does that mean to your heart?
It's not being oxygenated because it's not closed.
So what does that mean to its workload?
So it's hard.
So most valve people lead to the road of heart failure because we are overworking the heart. With this said, and I've told students a lot, but I'm trying to give you all I got in one dang day. In the world of heart care, the only thing we can actually fix quickly and work our rhythm, pacemakers, things like that, because that's an electrical problem. But the rest of it, whether it's a valve problem, an MI, heart, we're going to heart failure. All roads lead to heart failure. And my analogy, and they used to tease me about it, was there's a lot of different ways to get shot. Some ways are quicker. And MI, we're part of the wall, guys. It's like taking the straight road to shot. Years of chronic hypertension may take longer. Back road, you're still heading for heart failure. Valve problems, heading for heart failure. That's kind of the end of the line for most of these things. Last, pericardial friction rub. What is that? Does anybody remember? So that sac that's around the heart, when you have heart attack, the heart is a muscle and it's going to swell. It's going to be inflamed just like any other injury to a muscle. So the friction rub is when you hear the space in that sac, when you hear that grinding when there's fluid in it. And so it sounds like, rubbing your hair. But instead of a pleural rub, which is your lungs, same kind of scratchy sound. This is the pericardial rub, scratchy sound, means the heart muscles inflamed. Make sense? So after an MI, I would expect someone to have a friction rub versus someone who maybe has because they're not there yet, endocarditis, things like that, where it's an infection of those vasculature. If I walked in and I heard the rub then, that would be concern. That whole thing about expected versus unexpected findings. Yeah, I know my post-MI should make that sound. Other people probably shouldn't. So if the cardiac assessment is fuzzy to you, just go back and look in your catheter book. Or watch a catheter video. It's okay. It's been a long time since you really had to get, into this stuff. It's been a long time since 114. I don't expect you to remember everything, but I do need you to go back and refresh. That's all. And once you see it, usually you're like, oh, okay, got it. That's good, great. Okay, so let's talk about if you made your notes in the way that I suggested. I usually start with risk factors, right? So if I said we were going by the concept, when you see those up there, guess what? They're all the same for everything we are going to talk about. So, that kind of one-stop shop model where I'm saying everything right at once works very well. There's nothing up here that is new, so we ain't even going to talk about it. Cheeseburgers line the things. Walls of the arteries get stiff and can't adjust. Metabolic syndrome, of course, diabetes, the whole 9 yards. Nothing up there. You know the difference between modifiable and non-modifiable, so nothing up there is new to you. Or if it is, we've got some problems. We talked before about stable angina, so remember, this is where it starts. We've had CAD for a while, and we've ate our cheeseburgers, and we're out mowing. It's usually exercise-induced or physical activity-induced, because, again, this is a progression. So you're out mowing the lawn or chopping the wood or whatever, and they feel the tightness or the heaviness, radiating, whatever. But when they stop exercising, what happens? Goes away. Or if you take your nitro, goes away. So we say stable angina because there is no tissue damage. There is no necrosis. As long as you stop and the pain goes away, no harm, no foul. With that said, so here they may live, you may live in this area of heart disease for many, many years and be able to be controlled with nitro. Okay? We're not doing a cath lab or a cabbage at this point. Why is the pain so big? You all remember? Why do people get it in the neck, the jaw, the back, the arm? Some people it's an elephant. Some people's just in the leg. So your heart is just not innervated like the tip of your finger. So everybody interprets this differently. Some people can be like, oh, I've just really been tired and I just don't feel right. And you look at the monitor and you got a big tombstone. And then other people look the part. So you cannot tell by looking at someone or based just upon the pain what level of cardiac involvement is happening. With that said, and I'm going to get on a tangent later, but I want you to appreciate, especially where we're going in your test, when we say assess for chest pain, do you think that, so say you have your typical patient who starts in stable angina, then we're going to go to unstable, they go to cath lab, they say they fix, one occlusion, but they're like, no, you really need open heart surgery. So you have open heart surgery. Are they going to have pain throughout that whole endeavor? Yes, no? I mean, if you had your chest cracked, is it the same pain? So people will say the whole way through, I'm having chest pain. But not all chest pain is the same. There's the chest pain from the tissue dying, the myocardium. There is the pain from pericarditis. There's pain from stenocarditis. And you have to be able to sort that out. Because when you walk in the room and they're like, I have all the pain in my chest. The only way you can tell a problem not a problem is start asking a lot of questions. Does that make sense? And my favorite is always just like, is it the same pain as when you came in? Because that's a phone call. Versus, do I look at pain medicine for your, for your incision? Or is it just related to pericarditis? Does that make sense? You know how you can tell it's pericarditis? Very good. A really deep breath. And you're sitting up, sort this out because people do get included. Those stents are not perfect. Sometimes they'll clog again. Sometimes what happens mostly in cardiac land is when they go to cath lab, you're only stenting the stenting lesion, the one that's the worst. But you probably got 2 or 3 more, and that's what they're going to fix on the cabbage. So never assume, oh, just maybe they give morphine. Well, what are we talking about? Because it hadn't helped you if you gave morphine and he was extending. That won't go well. Okay. I just want you to look at this for a second. It's on your case. Because this is, to me, what happens on your test. And another thing I want you to think about, and when I ask you to study differently, is to start prioritizing your notes. So that you're not thinking about what's the most important medicine, what's the most important intervention, what's the most important sign or symptom. That the first time you think about it is not when you're looking at the screen. So when you look at all of this, I'm going to let you read it, and what I want to ask you is, what is the one thing that you find most concerning? Perfect. Now, does he have, and this is very reminiscent, this is so consistent in your patients. Do you have a lot of things up there that are concerning? Yeah. You have, you're like ticking time bomb, right? You got a lot going on. But the fact that it's enough to give you a headache, what would be my next question if you said you have a headache? And I think it's coming from your blood pressure being too high. Yep. That's next on the list. What additional information, what other questions would be relevant to asset or uptake? We know a little bit. Well, what don't we know?
You ask about diet. He's eating out all the time.
Okay. Fair. What else? What else in cardiac plan is huge as far as your, without giving it away, health sustain? If your father died of a heart attack at 41, what's your risk? So history is not up here. In history, cardiac plan is huge. Huge, huge, huge. Also, we don't know about, meds. Are you supposed to be taking drugs for that one? Is there anything besides lisinopril? What other issues do you think, just based on this, because we see the cardiac stuff, but remember what I told you before, is that he probably doesn't just have a heart problem, right? So what other problem with this little cluster of symptoms? What other problems do you feel you might have? Okay. Okay. Not something.
Well, he smokes, so you can have COPD.
Definitely could be coming from your joint, right? If you have, so just the fact, and Charity said it, just the fact, so when people smoke, what does that do to their lungs as far as compliance? You get sick, right? How does that affect your heart? It's got a pump against what? It's got a pump against the stiff lung. So I know by definition, when I look at that little history and it says you smoke, I know we're going to have a harder go on this. You're going to have a hard time getting off of that. And you're going to have a whole lot more complications on my side watching you because we're asking that heart to pump harder. It's a very just that little fun fact there, to me, is relevant that I'm going to have problems like that. So, other thing that's probably, do you think he might be diabetic? Do you think that kidneys might have some slippage? Probably. So when they do those big panels, essentially that's, those are their thoughts. Now, we got some lab work. And what I want to know is, what's your number one? There's a lot of bad things on here. But the test is going to ask you, what is the one thing, where are you going to start? And mind you, where you're going to start is what's going to kill first. Alright? That's where you're going to start. That's your ABC, that's your priority. What's most likely to take you out, and then you work your way down.
BMP.
That is really disturbing. That BMP. So what does that BMP mean? And it has some degree of heart failure. So instead of you coming in, looking like what we thought, and kind of a train wreck, no. You indeed, where it says a moderate cardiomegaly, yes, it is stretched to a point, and probably the reason those lung sounds are diminished is that you got some heart failure involvement. Now, let's go with, what's your number two? And they're ugly. But if you think about it, how are we going to treat that? We're going to put on, Zocor, whatever. How long is that going to, is that, when you think of your time, what you need to focus on early, it's going to take time for the Lipitor and the Zocor to even start to move those numbers. So is that the first pill you grab? No. So his sugar is high, and in this world where you talk about sludging, and yes, what they found, research found, so we would put people who are not, it was not uncommon for people who were not diabetic to have an insulin drip after heart surgery because it's so stressful. But what they found is, if you let sugar if you didn't keep it in a very tight control, the mortality rates went up by 50%. Huge. And this is just about blood sugar after heart surgery. So yeah, controlling that sugar, I'm like you. And also watching, my number three is probably watching that creatinine. Because where we're headed with him, we're going to push the limits, right? We're probably going to shoot him with dye or do all kinds of crazy crap that's only going to make it worse. So we'll do this together, but yeah. So what, if you had to do his three problems, I think we got it. My number one, it has to do with that degree of heart failure. What's that looking like? That should guide your assessment. If he decides his lungs, I might have heard an S3, right? Something to listen for. I may be looking at his JVD. I may be assessing his liver to see if it's full. I may be looking for his puffy feet.
So if it be instant like that, what would you just maybe do diabetes?
So that's what I mean. He's probably got some level of that. And so yeah, they're going to pull off some of that fluid. Now, again, this is where I'm trying to take you further up the mountain. We already know that his kidneys are, right? And then we shoot lasers. I just want you to appreciate it doesn't always work. So, you ain't getting 40 or 80 lasers. But he just came back post-cath and we wrecked out his kidneys the rest of the way on the dye. And then you got So you give them 80 of Lasix, and you got 50 cc's in your bag. That wrong? For whatever reason, I hate this about this curriculum. All the reading stuff is in 213. So the short story is, most of the time what they do, they're going to push the kid in front and give maybe 2-3 doses of Lasix. Only way to get that fluid off is like dialysis land. So when you get to the point where it impacts their breathing, you have to pull it. But there's no, if the kidneys don't respond to the diuretic, there ain't nowhere to go. Fun fact. So here we go. We have talked about all these diagnostics before, but what I want you to at least appreciate is if I ask you what is the priority, it's going to change depending on your disorder. What's the priority for the CAD and NUR? You could only pick one. Which one matters? So in this land, which one is clinically going to help you decide which direction to go? What do we base our decision on going to cath lab or not? I need a cricket app on my phone. I'm not usually, like family thing last night, so I was at like 1. So, the EKG, that ST elevation and all that good stuff, that's whether or not they're going to go to cath lab. Okay? The troponins, it's the higher the level, the higher the more injury, if you will, so it corresponds. They'll do the first set when they're drawing all the rest of the blood, but nobody's going to wait to see what the troponin comes back to see if you need to go to cath lab. It is all based on that ECG. Where the troponins come in, really, are the people who are borderline where the EKG you couldn't, maybe there was a smidge, but you couldn't really tell. And so say it's me, and I keeled over, and you took me over to whoever does not have a cath lab. And they're like, it's kind of borderline, we're gonna rule out MI. So my first set is, not elevated, and maybe, my second set, Charity's taking care of me, my second set comes up at midnight. She got really busy with the new admission, she forgot to check, and it was sky high. How does that impact me? What does that mean? Actually, it's going to impact her badly. But if I came back with a really high troponin, what does it mean? If she forgot to check, and so for 8 hours until a physician came in, I should have been on my way to central or whatever proper. So those are kind of when I say, the backup plan, but sometimes, particularly in the people that are borderline, are super important. If I had a prior diagnostic for heart failure, we just talked about it, which one was that? BNP, because I'm looking at stretch. We're going to take a guess, I'm a little ahead of you right now. If I had a prior diagnostic for valves, I need a picture of what's happening. So which one is that? It's the echo. And of course back to the rhythm, back to ECG. So your priority is going to shift based on what you think what your recognize, analyze cues, what your assessment findings, whatever direction that is pointing to you, that changes the priority assessment. Now we know we're still in stable angina. And I get really rowdy with this stuff, so when it gets to be break time, I won't let me keep going because I'm going to I think you know this. If you're post cabbage or you're on cardiac step down, you're out walking your patient around and they're like having chest pain. Do you walk them back to the bed? No. Oftentimes students will say, well, it's always funny if I can find this cartoon someday. I will. It's hilarious, but it's like if they have a history of COPD, like you probably have, and he's a smoker, they don't like to put oxygen on him because they think that we're going to knock out the driver. Well, let me assure you, it won't happen that easy. 2 years ain't gonna. He gonna die of chest, heart attack before the CO2 kicks. So the other thing is it confuses them because when you do a SAT, it says, well, his SATs are 98. Why should I put air on it? Why are you having chest pain? Because this is not getting enough oxygen. Don't matter what. It doesn't matter what this says. You always put air on them. Okay. Go back. Remember the nitro thing? Times 3 doses, Q5 minutes. Be able to, explain that to your patient, going home, that sort of thing. I'm going to tell this to you. I told this to paramedics, and you missed this question. This is your fault. I will literally come back in here and laugh and he-haw you. Okay, so here we go. All chest pain is clinically significant. Now let's put that into context. You have someone come in and they complain of a chest pain of 9 out of 10, and you're working in the ER and the doc orders nitro times 3. So you give the first one, he says it's 7. You give the second one, he says it's 3. You give the third one, he says it's 1. What do you do? Yep. And that will trip you up a lot because is it better? Yeah, it's better. Is it gone? No. And even a 1. It didn't take it away. And you need to go further. Does that make sense? Okay. And of course, morphine. Why do we give them morphine? Why do we give them morphine? What is it giving? I mean, and this sounds really bad. We give them it for pain, but is it really because we're kind and we don't want them to be in pain? So it is, yes, it helps on the respiratory side, it's slowing down the heart, because the more that pain is driving that sympathetic response. So if you can level down that pain, you can slow down that heart rate, and lower that blood pressure. We're doing it for that reason. It's nice that they're not saying that. But the more that sympathetic drives, the more chest, demand for oxygen, things just get a lot worse. With that said, your typical protocols is we give someone 3 nitros, and you give them morphine. How much are you going to drop their blood pressure? Anybody know? Okay. So think about it. Every time you give a nitro, do you have any idea how much you're going to drop them? Usually about 10 points. Some people will fear. But you think about that, and then you put the morphine on top. Probably another 10 points. So your best have had a pretty good blood pressure when you start that. If that makes sense. If you started out at 30, yeah, you'll probably be okay. If you started out at 100, you won't have very far to go. Most of the time, the docs don't want you to give anything below 90, but why? What happens if you drop below 90? What's going to happen to your chest? Better or worse? Again, cardiac output is what's going around and around, right? You turn down the faucet, and it happens. I have bottomed people down on nitro, not intentionally, but sometimes it just wallops them. Okay. When I said before, and when you get to heart failure, which will be, I guess, next week, on that PowerPoint, I gave you a very detailed list of the medicines that you need to know. So this is broader, but again, after a break, when we talk about studying, those medicines are going to be the same no matter what your disorder is. So if we can lay them down in one place, and we don't keep writing them for this is what you do for heart failure, you know, blah, 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 blah. If you're going to do something different, yeah, like the BMP, for example, for diagnostics, you would hook that over there, that's specific. But we typically do all of the same medicines no matter what the disorder is. So, I want you to go back to your betas, your ACEs, your diuretics, your cholesterols. Now, when I look at that, both the betas and the ACEs are going to drop their blood pressure. They're going to do what's called, we say, reduce afterload. So if the pipes are really tight coming off the heart, they're going to open up, right? But difference between the two, when I see a beta blocker and ACE, and they're both doing that, what's different? That's the beta blocker going to do, the ACE one. Slow your heart rate. So what you gotta worry about rate? Well, you don't gotta worry about rate. I think they feed the diuretics into you. You give someone cholesterol medicine, what's the one thing that concerns me that they usually worry about, Jack? What do cholesterol medicines affect? Your liver. So usually we look at LFTs, that sort of thing on that. At the end of the day, when we make our notes in this concept-based thing, all of the patient education is, guess what? Just about the same. Right? Then we're going to say the same thing for a valve, as we are as heart failure, as we are after an MI. I told you before, just, there's a few questions I know about, patient teaching and nitro, so just look at that chart. Make sure you're comfortable with that content. But nothing in here is new. I'm looking at this. If you read this, I want you to just tell me what's your number one. This is harder, but as I see this, okay, so when I say, I'm with you, chest pressure with nausea, but it's when she climbs the stairs.
Oh, I didn't say that, sorry.
No, you're good. So that to me means what? What does that sound like? Stable. No, I'm not saying she's a train wreck. She is. But currently, she's not having chest pain, but what? She's short of breath with activity. This may surprise you, but 3 days of progressive weakness on top of that is very concerning to me, because that means something is changing, that you are just now. Because particularly in women, fatigue is huge. A lot of them will just say, I just feel so tired. And you put them up, and they've got changes. So fatigue or this, I just can't get off the couch, in light of that background, concerns me terribly. When we look at her, what's your number one? That's not a good sign, is it? That and the fact that you are saying in this that you're 4 out of 10. And it's lasting. The other thing, and I didn't, it's not, I know it's a cluster of symptoms. Why are you having PVCs? Could you? Anybody know why jumping into this thing. So remember, they're premature ventricular contractions we talked about last time. We're going to do rhythms again, not today. But PDCs, normally fires from the SA node. They can fire from any cell node. So PDCs mean it's firing from somewhere else besides the SA node, and it's usually when it's angry. So you make your heart mad, and it starts throwing these PDCs because it's not coming out of the SA node. It's like you guys when you're overworked and you've had enough nursing school. That's how your heart feels, and so it starts to show out a bit. When you get these orders, so that you put her up, okay, you did the stuff, and then of course this is classic. At 3:30 in the morning, now it's on. So that's, every night shifter is like, oh yeah, great. So here we go, your standing orders. What I want you to take a minute is tell me, do your one, I don't know how many is up there, 6, 7. Just do 1, 2, 3, 4, 5, 6. Tell me what are you gonna do first? Now remember, NCLEX testing that you are alone won't do. It's a very strange and artificial thing, as I say this. So the premise behind NCLEX testing is that you have all of the resources that you could need, supplies, whatever, but you are absolutely and utterly alone with them. So there you go. Now when I say as far as the RN level, you can have help, but you have to be able to tell the help what to do. But you have no other army. So, in this lens, let's just talk it through. What's your number one?
Natural.
O2 is me, and I think in terms of time. This sounds silly. Yes, I would have my finger on the button of the bed. But in that time, I could probably get the oxygen on and hit the button because it takes, my husband's 6'2", and every time I get in the car, it's like riding a seat forward. It's gonna take me. I can reach the wheel. But so yeah, either one of those, head up, O2, I'm good. So this is where it gets interesting to me. Where are you guys going after that?
I like doing the ECG. We'll do it with focused assessment.
We'll go with, let's say we got a 10. So you can holler for that. Let's holler for that. Because most of the time you do. I personally would do my assessment before a diagnosis. That makes sense? So, particularly in the lens of NCLEX and testing questions, if you see your list of choices, you've got a problem. One is an assessment, you're going to do an assessment, and one is you're going to do an intervention. The whole premise of nursing is you can't do an intervention if you haven't assessed first.
They want you to add time, I think.
But always know, even if you're looking, I get a total strategy. But if you're looking and you're like, there's nowhere in there that said, in the stem of the question that says, we need to assess him. If you just spam on intervention, because they want to make sure, and it makes sense, that your interventions are based on your assessment. So that's just a general rule. So for me, yeah, it would be particularly probably getting vitals and then doing an assessment in that order. I'm gonna hit them. I'm gonna spin the wheel because the vitals are gonna probably focus my assessment more. But point is, I'm not gonna start any of those medicines, particularly because I know I'm gonna drop your blood pressure. So I'm not going to start any of those medicines, and I'm going to listen. Do I have an S3? Do I have a new murmur? Like, what the heck is going on? That may change my mind in some directions as far as what am I going to do. And the 12 lead, yeah. But for me, and I told them, you can yell for someone to do that. For me, though, I in a testing standpoint and really in real life, I would holler for somebody to do it, but I would not do that before I did vitals and assessment. If this makes sense, if I hit a set of vitals and my blood pressure is 40 over 20, am I going to get an EKG? That ain't my problem right now. Okay? So that's what I'm saying. The assessment is going to drive for intervention.
Yes.
Sure.
Janet.
All right, Janet.
Oh, Janet. So she came in, she's a little bit overweight, and she didn't say she had chest pain, and she wheezes, she smokes, and she was going upstairs. And her O2 is low. Why would you not necessarily think like, oh, I'll be wrong?
Because that chest pressure, so why is more like a cardiac. No, she probably does have COPD, because usually they all wrap together. And even that, you're perfect. Are the wheezes from smoking? Probably. But when they do this, you can't really tell. As long as you're not drowning in your own fluid, it might be from the smoking. But I do think it's more of this chest pressure, this nausea, the shortness of breath, that activity could be the smoking, but probably more the pressure or nausea is not feeling the COPD.
Did she more of that? They described it more tight. And the other one's more
So no, that's the heck of it. It's like people are not great at storying. So you have usually younger, when I say younger, elderly males are the classic elephant on the chest versus what I said before, women will be like, I'm just really tired. I don't know, it feels kind of heavy. And that they'll have like this big extended. So you can't tell how bad it is by looking at it. That's a hard lesson learned. That, and I'm going to give you a break now, that and always grab the vomit bucket because they puke. I still want to click. We did, Janet. We did this. So, acute coronary syndrome is this umbrella term, remember, for the next breath. So maybe we stayed in stable angina for 5 or 10 years, and it was exercise induced, and then one day we're sitting on the couch watching Netflix, and you have the same chest pain. But you're not doing anything. Okay, so you have that chest pain at rest, and you take the nitro, and it doesn't go away. So either chest pain at rest or chest pain, even if you were exercising, that is unrelieved by nitroglycerin, means that you have moved into the world of unstable angina. Ideally, this is a point that you treat and go to cath lab, because there is still no tissue necrosis. But denial is huge. Nobody believes they're having a heart attack. I probably wouldn't either. I talked myself out of it if I could. So most of the time, people just kind of diminish it at that stage, and you either go to the non-STEMI or the STEMI. The non-STEMI is a partial block, the STEMI is a complete block. Both of them have tissue necrosis, and so that means the wall of the heart is going to die. Symptoms are very similar to the stable angina, sometimes more severe, and depending on the location of the blockage, particularly if it's on the left side of the heart, because the left side is the pump, that's where you're going to see more of the hypotension, the tachycardia, that sort of thing. if the infarct is on the right side, you tend to see more of the rhythm problems. Because that's where the SA node is. So, can often look like that more classic heart attack that you think of, where it said atypical. That's just what I said before. People who are diabetic because of the lack of sensation often will have the silent MI or a different presentation, just very subtle and vague. So that's why you really can't tell, and I told you women with fatigue, you really can't tell by looking at someone what's going on.
I'm sorry, could you say that one more time?
The neuropathy.
The hypertension, you
Ah.
said left.
Yeah, so usually if it's on the left side of the heart, you'll start to see those vitals slip because it's the pump. And the right side, because it's the SA node, you'll see more of the rhythm abnormalities. Okay, to me, where it says priority diagnostics, that looks like it's like all apply. I'm just saying. Okay? So, if you only have two, those are your two.
Better check the
Pick. Yeah. And I'm not saying they're not gonna. I was gonna say, every time she does it, there's one coming. It's with the valves. It is the valves. You know what I'm talking about. So when they do biologic valve replacements, it's a different day, but it's a good example. It's either it's either cow, or is it cow, pig, horse? Yeah, people pick squirrel. Like, trying. Anteater, whatever. Every year I'll put on different animals and they'll just go ahead like, yeah, I bet they do use dolphin valves. It's just like, wow, okay, come on. So no, here you go, gave you the answer. If you pick another, are they going to order every one of those? Yes. Is that the priority? No. Fortunately or unfortunately for you, we are not to revisiting the rhythms again. So as far as you being able to identify anything, there will be some ST elevation or ST depression, but we're not going to have any more rhythms than that. Remember that, to me, this one, I love this to test tube. This is your classic tube stuff, ST elevation. Remember, the thing's supposed to be tight. It's supposed to come back to the line right afterwards. Or ST depression. So below the line, that's all I need you to be looking for. Okay? Can we do that? This or this? It's the only thing on our test as far as recognizing a rhythm. Something that's often, I think, confusing or that trips you up on the test. When you have an MRI, whether it's a STEMI or a non-STEMI, these all dots. So when we take them to cath lab and we open the coronary artery, yes, the blood's moving there now, but what died. Does that make sense? So we are not fixing that. We are trying to reperfuse it. We were hoping that there's enough of it left to still be functional. But we can't fix that. So that is why oftentimes after cath lab, and they bring you back up to the unit, yeah, you may have a pressure of 60 or 40. They opened up your artery and they stented it. It was beautiful. But the wall died. Does that make sense? Just put this back. This is not on your test. I just want you to appreciate the reason we always get a 12 lead is that in showing each of those areas shows a different part of the heart. You can have a perfect lead 2 or lead 3 on the right side and be infarcting on the left, and you will not see it. So our monitors are usually only in one lead. You can't look at that and think that you're seeing So each of those areas corresponds to the different, part of the heart. And that's just a protocol. Boy, that's busy. We ain't going there. This is more of our goals. What are we trying to do? Obviously, reduce the extent, reduce the cardiac workload, all that sort of thing. Whereas I folded out treatment guidelines. This, and I think the next slide, I something in there tells me I'm feeling some select velvet apply. So just go down there and look. I personally love select velvet apply for complications and treatments. They're really super great. Very effective. I know. The good thing, yeah, well.
Because then I'm like, I get shot. I pick them all.
That's before they changed the next gen. So I felt like I was all in that. So it really was awful because they just always messed up. Like, it was a complete For time's sake, I think we did this before. You've seen that balloon angioplasty video and all of that. Remember, that's what they do. They usually cannulate the femoral artery, they run it around, they inflate it, stretch the wall of the cheeseburger artery, and then hold the stent in place to keep it open. Question to you is, okay, so in the early care and pre-hospital care, they give you aspirin. Why do they give you aspirin? No, we got better blood thinners. This is antiplatelet. So remember, what really happens is you have all this. This is your cheeseburger lining. One day, one of these plaques breaks off and goes forward. Now, it might go to your coronary arteries, it might go to your head, and that's why you stroke, but it's flying forward. When this flies forward, who comes to stop the injury? Our friend, the platelets. So what causes the STEMI, the actual, complete occlusion, it's not that you fully occluded on cheeseburgers, it's that the platelets came to the injury site and they stopped the blood flow. Does that make sense? So the aspirin, cheap, no harm, no foul, antiplatelet, try to reduce this in route. But when it's moving. I hate this. Hate you. It did this to me the other night. Just hate it. Hate it, hate it, hate it. Don't have a clicker. My clicker doesn't work. Now it works. So, when they come back from cath lab, sometimes they heparinize them. It's a very physician thing. Sometimes they do heavy antiplatelet meds, Repro, Tegrelin, things like that. What does that mean to you as a nurse? Larry, you're a player. Where you want to be. Because we've cannulated your artery, and now we have pinned you down and knocked out your platelets. Okay? So your primary concern post-cath lab is two different things. Number one, heart SMAD. So where it says perfusion arrhythmias. If any of you are precepting on ICUs or whatever, or post-cath, and you'll hear them, they'll have short little runs of ETAC. And the nurse will say, oh, he's just reperfusing. But most of the time, the reason people, if they make the cath lab and yet you die from their life, is from arrhythmias. The heart is just mad. The wall died. So arrhythmias are an issue and bleeding are our issues. Not just from the site, but, and I told this story before, I always tell it because I think it's relevant. You've got the site, but you also have retroperitoneal bleeding, which is bleeding into your back. So sometimes when you cannulate the artery coming up through here, you nick it. And so you bleed So I went to a code because we were the code team on our step down unit, and some woman in her 40s who arrested. We did not get her back, but she had a retroperitoneum. Now, I think that was a nursing failure. Why? Should you not have been able to tell she was bleeding to death? How would we have been able to tell? What should she have? What should her nurse have seen? I mean, we should have been trending. Yeah. Your blood pressure keeps trending down, your heart rate keeps trending up, you have no urine output, I'm sure at some point your mental stats. A lot of things happened before she arrested. But by the time she coded, it was too late. So yeah, looking at people's, knowing that that is always, we see the visible sight, and a lot of times it'll bruise and you'll get hematomas and all kinds of ugliness here. But don't forget they can bleed into their back. The other folded out, another place where I know there is something to do with the test. I do. And weirdly, although it's not folded, I know those complications. It's like almond plaque. So highlight those and look at them. Post-op cath care, we talked about this before, but if you're not comfortable, go back. Again, we're assessing not pules, but pulses. And that's not nausea and vomiting, but neurovascular, because they cannulated one side. So when you're testing sensation, when you're looking at, you're comparing the cath lab leg to the other leg, does everything make sense? Did you get a clot in that cath lab leg? Absolutely. And so we're looking to see, because that plaque took off, and doesn't mean there was only one. There's other big particles floating around, and they land in weird places. So yes, we do a lot of site checks, pedal pulses, looking at rhythm, other organs, because I told you we shot the dye, and complications. Did you re-extend? Are we still having chest pain? All of that good stuff. Did it work? Now, cardiac caths can be diagnostic or interventional. Depending on where you work, if you ran somewhere for a diagnostic cath, yes, I'm sure checking the site and doing all that, but it's not like the wall of your heart died. So someone with a diagnostic cath, I don't have the same concerns as someone who went in because they had an MI and they were stented. I know that wall died. I know that heart is very irritable. So my arrhythmias, my concerns for like a heart failure kind of presentation are going to be with the interventional cardiac cath, not necessarily diagnostic. Whereas the bleeding, the hematoma, those assessments would be the same for both.
But an MO person, like stents, would be a lot more.
They're a lot sicker, so they're probably going, whereas the diagnostics are probably going, it's almost like like they're going through every day and they're popping them out at the end of the day. The guys who came in and had an MRI or whatever, they're going into the unit and they're probably going to rest them overnight and make sure that we don't have arrhythmias or that we don't develop heart failure.
Potential complications than just a diagnostic.
A diagnostic usually, if they don't have bleeding issues afterwards. Almost done, guys. Stay with me. Sometimes they do thrombolytics. Why would they do thrombolytics and not a cath lab? So what if it's smelly and I have my MI and I'm a Blue Ridge? What am I going to get? So it has a whole lot to do with access. Thrombolytics thrombolytics, of course, are, primary for stroke patients. But for heart patients, we want to go to the cath lab. Of course, that's our priority. Thrombolytics are only if you don't have no cath lab. However, what is the risk of doing someone with thrombolytics? Bleed, right? Bleed. Oftentimes, when we would see this, same thing, snowy at Cannon, snowy at Blue Ridge, couldn't fly, whatever. So they went ahead and just shot the thrombolytics, and then they didn't work. So then they bring them to us. Where do we go? Cath lab. But you're going to cath lab with someone who's had thrombolytics. So what does that mean? So yeah, now, and so even when they do that angioseal, that sealing thing, that gooey gel that seals it off, a lot of times that thing, if you had given thrombolytics, it'll just start bleeding onto the pad. You can tell these are things that have happened to me. So after not very long in the cardiac ICU, and this sounds mean, but and I always looked at night, but they don't have these. You get a loincloth. Before everybody comes in the morning, push back together. Mind you, you're on the vent, you're sick as heck. But no, if you can't see these people, they are that sick. They will literally, they've got arterial lines and stuff. It takes nothing for them to just bleed out in the bed and you got that nice blanket on. Never. So yeah, everybody got stripped naked pretty much. At this point in time, NCLEX test, or do you know what NCLEX test one? Basic competency nursing. Okay. If you pass NCLEX, that means you are minimally competent to not kill someone. That's all it means. But I'm not trying to turn you into a cardiac nurse. If you want to do that, you will figure it out. You will take a whole lot of other certifications, all that crap. But my point is where it says the cabbage. I'll show you this video just because I think it's interesting, but not a whole lot of questions on the cabbage. I'm not trying to get you yet. But if you think about it, and so go back to where we started. So let's watch this video, and my last question for you is going to be, if you were taking care of this patient after the surgery, what are your concerns? So I'm going to pause it. We're going to watch a movie. We're going to build our notes.